to start screening. Go live.
Kailash is here, but still probably we need to check.
I have started live on YouTube now.
Can you see it on YouTube? It's ready now. We are live.
Uh,
You can proceed.
Ajit, go ahead. We are live.
So, very good evening, friends. Today we are starting our UPOA hand webinar. This webinar is this series. This will have many webinars. This series has will have many webinars. We have very learned today from the different part of the world. They are not only the good speakers, rather than they are very good surgeons too. And this webinar is completely focused on the hand and wrist injuries. We have with our president, Dr. Atul sir, who IOA elected president, Dr. Atul sir. I request Dr. Atul sir, please have some words for this webinar.
Well, good evening all. I will not take much time. I know we have a fantastic panel, and I believe that we are in the best of hands for today's hand symposium, and I'm sure this webinar is going to be very handy for all of us. Thank you.
So further, I will request Dr. Sanjay Dhawan sir, our Honorable President of UPOA. So please have few words.
Thank you, Ajit. Very good evening to one and all present here. I welcome you all for joining us today on this UPOA hand webinar, the Friday Musing, organized in association with Kanpur Orthopedic Association, and I congratulate them for taking this initiative. My sincere thanks goes to our guest speakers, Dr. Anil Bhatt from Manipal, Dr. Ravi Bhardwaj from Kolkata, and Dr. Pankaj Jindal from Pune, and our panelists, Dr. Ashok Visar, Dr. Santosh, and Dr. Unmesh Chakravarti, for sparing time and enlightening us with their wisdom. I'm sure that every bit of their talk is going to give us certain practical tips, which shall be very useful in our day-to-day practice. So without wasting much of your time, we'll just move on to academics. Once again, I welcome you all with best wishes. Thank you.
Thank you, sir. I'll request Dr. Anup sir, our Honorable Secretary, sir. So please have your words and have some introduction of our panelists, please.
Thank you, Ajit. I have a bit of information that how UP Orthopedic Association is going to help all our member and other orthopedic surgeons, even during the pandemic or after the pandemic, through these online channels. We have planned thoroughly for coming months. Every month on first Friday, we'll have a webinar on arthroscopy. Second Friday is reserved for trauma. Third Friday is for hand and wrist and upper limb. And fourth Friday is for pediatric orthopedics. Apart from that, we'll be having orthoplastic course on 18th of July. Then in August, we'll have an arthroscopy course. Then in September, we have midterm symposium. Then in October, we have UPA orthopedic trauma course. Then in November, we have PGICL. Then in January 2022, we have EPG on. And then another February 2022, we have an annual conference, the OrthoCon. So we are committed to provide excellent academic opportunity to each and every member. And I'm thankful to all our members and teammates for helping me in doing all this. So thank you everyone and welcome. Thank you, Ajit. Over to you.
Thank you so much, sir. So now I'll request our honorable, Professor Dr. Anil Bhatt, sir. Anil Bhatt, sir, is an excellent teacher. He's always loved by the students. He's a professor in KMC Manipal. He's a dean of also the Manipal University. So it's a pleasure and honor to invite you, sir, for this talk. Distal radius fracture, intra-articular fracture is one of the most common injuries which is encountered by the orthopedic surgeons. So the best thing is that the most important thing is how to deal these kind of fractures, how to get best out of these so that the patient will have predictable outcome. So to enlighten this problem, to enlighten this fracture, we have Professor Dr. Anil Bhatt sir. So Anil Bhatt sir, kindly start.
Thank you, Ajit. I'll be sharing my screen.
Yes, please.
Right. I think, thank you so much, Uttar Pradesh Orthopedic Association, for this wonderful opportunity and invite. I was there in Kanpur 2.5 years almost, 15th March. And this was a photo taken at the end of the course there. It was a wonderful time we spent the entire day. I'm missing Abhijit today. And to set the record straight, Ajit, I'm Associate Dean and not the Dean of KMC Manipal. So coming to my talk per se, for me, every distal radius fracture is an intra-articular fracture. And why do I say that? Is because if you see, the distal part of the radius is just not an isolated kind of a bone there, sitting there. It's actually a part of the entire joint, that entire radioulnar joint. And it also participates in the wrist joint here. So the radiocarpal here, the distal radioulnar joint here is directly in relation. But if you know that during Galeazzi fractures, we have intraosseous membrane involvement, DRUJ involvement. So in that sense, the distal radius fracture is actually, any distal radius fracture for that matter, is an intra-articular fracture. Now, when you see a patient with distal radius fracture, obviously the first thing is to ask for proper history and also for clinical examination, especially complications like compartment syndrome and neurovascular deficits. The median nerve compressions have to be recorded when the patient comes in. We asked for the x-rays next. The classic x-rays to be asked for wrist is always a PA view and not an AP view, a PA lateral and an oblique view. And the basic idea for you to ask x-rays to check for stability, articular extensions, and associated injuries. When you take these x-rays, the most important thing is to look at all the corners of the radius. What I mean by corners of the radius is basically for the intra-articular fracture, especially. Now, if you look at this x-ray per se, you should be very closely looking at this part. And you should be looking at both the lips of the radius. That is, your entire articular surface sitting there. The scaphoid and the lunate is articulating in these two areas. So that part, if a properly done wrist PA view, it will always show this very beautifully. And you know straight away the X-ray gives a lot of information which part of the articular surface is involved. The other one is here. So the sigmoid notch. So this is also a part of the articular surface, and we should not be forgetting that. So that's why I said, look at all these corners here, nook and corners. In the lateral view, again, look at this corner. This is a very vital area for us to look for, the teardrop area, where there a lot of energy, lot of forces, when they act here, they make the wrist very, very unstable. So never underestimate these fractures when you see this. And in an oblique view, again, the sigmoid notch and the lunate facet is very nicely seen. So if you look at these corners and these articular surfaces, most of your answers are there as to what you might really not require a CT if you really start looking at these X-rays very carefully. But sometimes you might dismiss this as an extra-articular fracture. Be very careful, because very subtle intra-articular fracture lines can be seen exactly on the CT axial scans. Okay, so these are the ones which should not be taken off as extra-articular fracture and undermined in terms of the treatment. They have to be taken care of and see where the fracture lines are running. Now, there are numerous classifications, but most of them should guide your treatment, especially in terms of stability. And a combination of it is what you should be having in mind, which means to say that Frickman's talks about radioulnar joint. No other classification talks about radioulnar joint and ulnar styloid. And the Meadows classification talks about the fragment specific. The Rickley and Regazzoni talks about the columnar concept, and the Fernandez talks about mechanism. So each one is talking different things. As a surgeon, you should be combining all these in your mind. Is the radioulnar joint involved or the ulnar styloid involved? Which part of the articular surface is involved? Which column is involved majorly? And what is the mechanism which will give the treatment? Fernandez is the only one which tells you what treatment for what mechanism. So, but as a surgeon, I think in your mind, you should be putting all these together. That is what you need to do as a mental exercise, by putting all these in together and trying to come to a diagnosis in terms of management. That's very, very important. Now, I will take you through especially three major cases, three very difficult intra-articular fractures, and put in the principles and learning points through these cases, basically. So this is one fracture pattern. If you see, this is a very, very deceptive and very, dangerous kind of fracture, if I have to say, because a lot of times these are missed. These are classic lunate facet fractures. Now, when you say lunate facet, it's involving the lunate facet is also involving the sigmoid notch. Two articular surfaces perpendicular to each other are being involved in this. So if you take an oblique, like I told you earlier, it will give you an entire picture of how bad this fracture is here, right? And again, as I said, further imaging is always, again, don't undermine these, underestimate these fractures. Always take the CT scan, and your axial scan shows you very nicely where the fracture fragments are and where the lunate is being carried away. So this is a volar depression. So there's a direct die punch kind of an injury. If you see this shadow here, the entire subchondral bone is completely gone inside there near the lunate facet. So the lunate has pushed the entire subchondral bone inside, and the fracture fragment is carried by this. So it's more towards the volar side. So these are lunate facet fractures. Your 3D reconstruction gives you nice, glamorous kind of a picture, but a lot of times might not give you a lot of information compared to an axial view, actually. But yes, we routinely do that. We like to do it, and we like to look at it very fancily. But otherwise, it might not give you a lot of information for your management. So lunate fossa fractures is a type of intra-articular fractures which are often missed or underestimated. So you need to know what implant, what approach, what are the technical difficulties, and what are the complications in this. The most important thing is try to get hold of that fracture, which means your approach should be straight there, and you should be modifying your modified Henry's approach, which basically means that you might have to go towards the carpal tunnel here. So an extended FCR approach or a carpal tunnel approach is what is required for you to engage that fragment. That's very, very important for you to go all the way inside there, use your lever and try to get it there. So elevating that fragment, usually it is a depressed fracture. Elevating that fracture is very, very important. Okay. And sometimes you have to go through the fracture site to push it up and push that subchondral bone, pack it nicely from underneath so that you get the articular surface nicely there. Okay. And you have to fix, and your fixation should be quite enhanced here in this particular way. And you know that the distal radioulnar joint is also involved here. So you might have to hold on to that till you put in your fixations, which basically means a lot of times you might have to use raft wires like this. Then you have to put a plate. Your raft wires can go like this, basically trying to hold these fractures, hold that fragment. Very, very useful technique for you to use the raft wires. And when I said enhanced, means dedicated screws for that particular lunate facet. I put a screw here, extra screw here first, and then the plate has come here. And minimum at least 2 of these screws, the locking screws, have to hold this fragment. Minimum of 2, plus your additional screw might be required here, so that that gives you a very nice hold onto this fragment and don't collapse further. So very, very important for you to engage that fragment, elevate that fragment, and enhance your fixation with any of these kind of implants here. That's very, very important. If you don't do that, you underestimate this. This is another example, another case. So a fracture like this, operated. Yes, there are 2 screws there. Here you see a small gap there, a step there which the surgeon didn't address. There is 2 screws, but probably one is going towards the fracture side. And this is 3rd month. And by 3rd month, you see that it's already collapsing here, even though you put a lock plate there. So if it is less than 15 millimeters of the lunate facet available for your fixation, or greater than 5 millimeters of initial lunate subsidence, they are at risk of failure, even if a volar plate is properly placed. So the volar rim fragment of the lunate fossa is the Achilles heel of the distal radius fracture fixation. So that's why I put up this case. It's a fracture which a lot of us underestimate. We try to not really fix it and always end up with complication. So the learning points here is this. You read your x-rays well, look at your routine height, inclination, the bone stock which is available to you, whether it's intra-articular. If it is intra-articular, which component? Is it the lunate facet? What has happened to the articular surface? Always look at one joint above, which is the scaphoid radiocarpal joint, and the adjacent joint, which is the distal radioulnar joint. So all these have to be looked at very carefully before you start planning. Very, very important. Second learning point is unstable fractures. If there is a lot of combination, especially on the dorsal aspect here, or if there's an angulation of more than 20 degrees, or if there is a shortening of more than 1 centimeter here, it's a fracture or a shear pattern like this, or if it's completely displaced like this with a loss of the entire articular surface, or the ulnar styloid base fracture, or a very osteoporotic bone, all these are inherently unstable, which means we should not be using very unstable kind of flimsy fixations with the plaster or a cast, with the K-wires a lot of times. It requires much more than that. CT gives better information after close reduction. If you just take a CT when a patient comes, it's as good as a glorified X-ray. So always do the close reduction, and then you will get more information from that particular CT, where otherwise you will always get a same picture as the X-ray. So always do a CT after your close reduction. And for a fracture like this, keep all possible implants ready. It could be your K-wires here. It could be different types of plates, even suture anchors sometimes, or these rim plates, which are very distally placed plates, or even an external fixator if you're comfortable with it. I'm not going to tell which implant is best. It's the best person is you as a surgeon, but keep everything ready if possible when you know that there is a problem like this. And also know when to use what type of plates. I mean, when to use the plate fixation itself. Shear fractures like this, compression, which I showed you just now, is one of the indication, or a complex with hybrid kind of a mechanism, you need that. Bending and avulsion types can be managed with KYs or external fixators. And you also need to know what designs of plates. All of us are very familiar, but the newer plates, especially the rim plates, the fragment specific plates, where you want to use a variable angle, where you want to use your ulnar or dorsal. Dorsal, classically, if the major fracture fragments are in this corner here on the dorsal aspect. Otherwise, a lot of times we use the ulnar plates in this fixation. And as I said, be flexible on your operative approach. This is a carpal tunnel, extended carpal tunnel FCR approach here. Straight, you go towards the lunate facet fragment here. That's what you're supposed to do instead of a modified kind of Henry's approach. Alternate techniques, as I said, there are dedicated implants now for these lunate facet, especially specifically for this. These hook plates are available. The tines will go subchondrally here, and you can place this only for that particular fragment here and try to fix these fragments. Now, as I said, you can still use other implants, but it's in your hands. This is another patient again. Again, as I said, don't miss these fractures. Very subtle looking fracture here, but the CT shows the real picture. See the amount of depression already there, and this will definitely collapse over time. But this patient was not affording. We used a K-wire. We followed up the patient. Patient also had scapholunate instability. And this is at 3 months, and this is at 1 year. It still heals. It's a subchondral bone. It's cancellous bone. It will still heal. But at the same time, you have to follow them up very carefully. And the early signs of red flags, you need to get them back to the theater if patient is not affording initially or not consenting initially. The other case I would like to talk about is a very high energy intra-articular fractures, which is called as a rim fractures. These are like explosion here. It's totally exploded. The articular surface is exploded, right? And your CT definitely helps here. It tells you in how from ulnar side, dorsal side, how these fragments go. These are floating intra-articular fragments, which you see in all these. And this is that teardrop, which I spoke earlier also. So flexibility in approaches and implants is very paramount, because finally it's all intraoperative decision. So a close reduction like this first, and then all possible implants have to be at your disposal. Extra screws if you want, extra plates if you want to hold the corners is very, very important. 6 months later, if you see this 1 year articular surface is reasonably formed nicely here in this, and this is at 2 years. A lot of times we can't get palmar tilt in these patients when there is rim fractures. Very difficult to get volar tilt during your initial correction, but up to neutral is good enough. This is what I told. If you underestimate these fractures, just put in a plate, it just comes off. They all, by 2-3 months, they come back like this with this kind of shear, very distal shear fractures or rim fractures. They subluxate and come back. So you have to be very, very careful. If there is a capsular injury here, that needs to be addressed, and the plates have to be quite strong. So in rim fractures, you need to know which component, because here are the places where very strong ligaments are attached. And that is where they all get pulled up. The radioscapholunate ligament here, the long radiolunate, the short radiolunate ligament, the dorsal radiocarpal ligaments. All these are very strong ligaments which pull the rims away and into different directions. And that's what happens. The basic steps, all of you know, initially we always do a closed reduction and see what's happening, how these fracture fragments are falling back. That's very, very important. Before, as a surgeon, you have to decide which implant. Before you open up, you always do under C-arm, you just check this and see where these fragments are and how are they moving. Very, very important. Try to hold them as much as possible just before you open up with your raft wires or K wires, if you feel that it's very difficult once you open up. Otherwise, you can straight away open up. Third is, in the rim fractures, you should know the concept of watershed. So here, this junction is where the pronator quadratus is ending, and here is the junction where the tendon is inserted, and from there the capsule starts off. So it's very, very important. So this is the entire pronator quadratus here, and this is where the fibrous tissue of capsule and the tendon junction is. That is your watershed line. Now your regular plates, if you place them here, right? If you place directly here, it can't go further. If it goes further beyond the watershed line, it becomes very prominent. So why it is important is your tendon, which is the most important, is the FPL tendon here. So if you place the regular plates here with a thick profile like this, your FPL is the one which will get attrition. So you need to have dedicated plates. So this is the exact area of watershed line, the junction between the distal extent of the pronator quadratus and the origin of the ulnar radiocarpal ligaments. Okay. Nowadays we get these implants, some which are designed to cross this area, but they're at low profile. So watershed line is not sacrosanct in that sense. You can go all the way till the end here nowadays, because these are low profile, and here these distal screws, the holes are angulated in the opposite direction. It's not towards the joint, it is away from the joint. So in that sense, there are different designs available. I generally don't use this, but these are the ones which are helpful in these rim fractures. So very, very important how you want to use them, how distal you can go, and still how do you actually save the flexor carpi, flexor pollicis longus. Other thing is this: when you have this radial styloid like this, the brachioradialis is the deforming force here. So always when you start your surgery, make sure you release the brachioradialis all the way there so that you get this back very nicely. Otherwise, reducing this big chunk of radial styloid is very, very difficult. So go all the way, you would almost see the first dorsal compartment, the tendons there. So release the brachioradialis and your reduction becomes easy. Third is, again, somebody has to hold this. The moment you use your cortical screws and trying to put a screw there, always the plate slips. So make sure somebody holds it all the way till you put in the screw. Very, very important. Fourth is, start from the ulnar side and go towards this, because you have the Lister's tubercle. A lot of times, if these screws are very long, they are hidden. So always make sure you start from this and then go towards the radial side. These are basic principles. You can always modify based on different cases. So in a rim fracture, again, more options. As I said, try to engage all these fragments using raft screws, dedicated screws here, using these kind of a combination, or sometimes we might have to use, we can't put screws, they're so distal, we might have to use fiber wires or ethibond wires through the capsule and just hold the plate there. So all the way distally there. So that could be done. As much as possible, try to suture the pronator quadratus back. In high energy injuries, the pronator quadratus is lacerated, but otherwise, if it is intact, if it is thick, fleshy, nice muscle in a patient, always try to, and always when you start dissecting, always keep a rim of this near the periosteum here and try to suture it as much as possible so that your FPL and is not irritated. The plate is nicely covered so this is what happens. If the plate is exposed here and it is proud, your FPL is the one which is getting irritated there. So always try to close that very nicely as much as possible with whatever tissue you have. Another concept nowadays, when you have these rim fractures, is an internal distraction plate. Instead of using an external fixator, we use a plate inside like this, kept for about 3 months here till all these fracture heals. You might do some minimal fixation here, but add this internal external fixator, if you want to really call it, and put in the plate there and hold it, and it has to be removed after 3 to 4 months. So the role of external fixator might be reduced in these patients. The last case I'm showing is, again, a high energy trauma. If you look at the pre-op X-rays here, you will see why I'm showing this is because there could be involvement of the carpus also in distal radius. And even the distal radioulnar joint could be involved. Again, a high energy kind of a shear injury here, and you have a gap here. So to be very careful, always look at the wrist joint and see what's happening there also. So you will see that the scapholunate gap is increased. So you might do a beautiful fixation of distal radius, but patient always comes back with wrist pain because the scapholunate was not addressed. So this is the gap here. He also has got ulnar styloid base fractures. If you just screen, as I said before your procedure, always screen the wrist. And you see that gap is increasing there. The capitate is trying to come in there. Okay. So very, very important that we have to address this in these patients. So again, same procedure, you can use these plates, go all the way distally there and try to hold this fragment, elevate the central depression there and use a wrap screws here and see what's happening. So now the distal radius is holding nicely, but the scapholunate gap is still there. So the most important step, and even the DRUJ is still not holding there. Most important is to get hold of the lunate. And the most important way or easy way is to get a radiolunate wire like this here to control the lunate, and then you put in your scapholunate wire. Very, very important that step. So use your scapholunate fixation here, and sometimes you might have to use one more here to hold the scaphoid with the scaphocapitate kind of a fixation. So now they are all moving together now. So that is what. But if you see now, the distal radioulnar joint is still widened here. So the story is still not over. So you have the DRUJ still there. So check after every plate fixation of the distal radius, always check the distal radioulnar joint. Look for the ballottement in all the three positions and see how unstable it is. And then either you fix the ulnar styloid like this, or you can use a DRUJ transfixation wire like this in this patient. Always intraoperatively check where your screws are. Okay, so this lateral tilt, 20 degrees lateral tilt will tell you exactly. This looks like it's inside the joint, but after, if you raise this 20 degrees, now you know that it's not so. So always check where your screws are. You can do the same thing with the PA view like this. It looks like it's there inside, but it's not so. It's a radial styloid screw here, which always looks like as if it's inside the joint. There's another view called a carpal shoot view where you can see that this screw is longer. You have to change it on table. So very, very important to that. This is the same patient. So it's not just distal radius. Scapholunate is fixed. Radioulnar joint is fixed. Radial ulnar styloid is fixed. So there's a lot of work in each of these patients. You have to look carefully. So in the end, I would again tell distal radius fracture is not just an isolated fractures. All should be considered as intra-articular fractures. Look for carpal and DRUJ instability and try to address each component as best as possible before coming out of OT. Don't take the patient later telling that you have DRUJ instability or a scapholunate instability. And results of secondary procedure are not as good as primary. So in summary, intra-articular fractures involves various components of the articular surface in different combinations. The implant inventory during surgery can be extensive. Be ready for that. Intra-op radiology to avoid implant-related complications, very, very important. All your tilt views. And don't forget the distal radioulnar joint and the radiocarpal joint assessment. Thank you so much.
Thank you, sir. It was wonderful talk. It's always pleasure listening you because the way you explain is really amazing. So there's some question. Dr. Sanjay Dhawan sir, our Honorable President, is asking question that in which position you want to put the wire to stabilize the distal radioulnar joint?
Right. So your distal radioulnar joint ballottement is the answer for that. So if you check and you see most of the time, it's always in supination, it can become stable. So that is the one. Otherwise, it's just short of full supination because a lot of people don't prefer to put it in full supination. It's sometimes difficult to mobilize them later. So just short, maybe 30 degrees of supination or even in neutral is good enough. Again, wire is not always required. If you can immobilize the joint with an above elbow slab for first 3 weeks, that is still good enough. And a lot of literature shows that even that is good enough, but make sure that you check, you know that there is instability, immobilize it for at least 3 weeks for the soft tissues to heal, and then start mobilizing them with a splint after 3 weeks. So that's what it is. When you put a wire, we remove it at 3 weeks, above elbow slab is there for 3 weeks. Make it a below elbow if you want, or you can put a splint if your fixation is good and start mobilizing them by 3 weeks.
Okay, thank you, sir. So next question is that how much depression is acceptable in the lunate fossa? Asked by our secretary, Dr. Anup, sir.
Absolutely nothing. In the sense that we are talking of, 2 millimeters, step off 1 millimeter and things like that. So in that sense, no, because it's a central column. It's an intermediate column which takes the brunt of the weight of your wrist. So, and it's got two articular surfaces, which I told this, both the sigmoid notch is there and the lunate facet is there. So it's a very important segment of the distal articular surface. So we don't want to accept anything. So try to give the best for the patient and try to get the best reduction as possible always.
That's the reason actually, Dr. Anil, I wanted to ask these questions, because I had seen a cases where on X-ray, you find just an undisplaced sort of rim fracture. And if you carefully look, it's only the depression of the scapholunate which you will find. So you need the CT to assess these kind of fractures. And unless until you see the CT, probably will not be able to get the justice. So most of these kind of fractures get unnoticed as an undisplaced distal radius fracture. They go for the plaster only. And many of the people, if you suggest them that these patient needs an operation or a CT scan, many of our colleagues, no, they just say, no, it's an undisplaced fracture. You don't have to do anything, just go for the plaster. So that was the purpose for asking this question, to put in attention to these kind of fractures actually.
Yeah. I mean, just even a limited, you see, finance or other things is a problem. A limited cut CT is always good enough to convince the patient about that. To convince somebody who knows about all these, it's very difficult. So that mindset has to change. And when you start seeing these axial CTs and everything, you realize how much of articular surface. See, first of all, we should get away from the thing that upper limb is a non-weight bearing kind of joints. Whether it's wrist joint, elbow joint, or whatever, they're all weight-bearing joints also. If you want to lift a 10 kg weight or a 20 kg weight, it's obviously weight-bearing joint. So that concept has to go from people's mind that it's not a not weight-bearing joint like a knee or a hip. So then I think things will change the way you look at it.
Thank you.
Unmesh sir, please unmute yourself and ask a question. Unmesh sir. Unmesh sir.
Sir, my question to you is, what do we do about these large? Yes, am I audible?
Yeah.
Yes.
Yeah.
Yeah.
So I'm asking is that what do we do with these large condyle injuries? Sometimes you have these large condyle injuries, and you just know it's just a flake of a cartilage, it's a flake of a bone. So what do you do about them?
Well, I actually didn't get the arthroscopy in because I know majority would not do that, but that is one way of looking at it, where you have to go in, scope the joint and do an arthroscopic assisted kind of a reduction, where you see these chondral elements and try to put them back and tap them back at the right places. If you don't do this, I mean, there's always an objection when I talk about arthroscopy, that is majority don't do, so don't talk about it. So that's why I didn't get that part in. But otherwise, you have to try to put them at least in the same plane as the articular surface, which means you do an intrafocal kind of reduction. So you go through the fracture site and elevate these chondral elements back there and put them as much as possible, so that when they heal, even though the hyaline cartilage might be damaged, at least a good fibrous cartilage comes in. And at least that gives a reasonable amount of movements and function for the patient. But we should not leave them alone. We should not leave them depressed, or we should not allow them to fall back into the that subchondral area. Is the CT axial view which I showed you, the free intra-articular fragments. Those are the chondral injuries which you're talking of. So don't leave them. Push them up. If required, put a graft underneath, like how you do your tibial plateau fractures. So give the same care here. But at least if they are in reasonable position in the articular surface, either you do from the joint, if at all you're doing an arthroscopy, or you do through the fracture site, push them up, keep them in a reasonable position so that they heal with at least good fibrous tissue at least. Yeah.
So, sir, what are the indications for doing the CT scan? Because most of the orthopedic surgeons, they have doubt when they should go for the CT scan, or when the X-ray is sufficient for decision making.
I think it's the same AO principle that every intra-articular fracture deserves a CT scan. Simple. So when you are suspecting an intra-articular fracture, you get a CT scan. I mean, when you're seeing an intra-articular fracture, reduce the fracture by close reduction as much as possible, get a CT scan. That is the first principle. Second, if there is any doubt, get a CT. You don't lose anything with that. At least it tells you where these fragments are, and at least you can always sleep better that there's nothing intra-articular. So it's not a very expensive investigation. It's not a difficult investigation, and you can limit your cuts if you want. Asking specifically for axial views or any of these views, you don't need fancy 3D reconstruction. So if you want to talk of finance, talk of radiation, talk of everything, still it's a worth investigation doing.
So,
Especially in intra.
So how to decide that? Most of the orthopedic surgeons, they have doubt that when there's a fracture of distal radius, and that is also comminuted. So this doubt is that that this whole fracture can be fixed with the single plate, or that will require the fragment specific fixations. Question number one. And my second question is that what is the absolute indication of doing dorsal plating?
Okay. So again, I think I'll have to go back telling that your CT axial cut will give you the distribution of the fragments, and it will help you in planning whether you want to use a fragment specific or you want to use just a volar plate or even a dorsal plate. So all those answers are given by that particular view. So if the first X-ray, first case which I showed you with, it's a very pure volar lunate facet kind of fracture, you can use your dedicated fragment specific. If there is a big, large radial styloid fragment, you can use a lateral plate if you want, if you're not using just K-wires. Dorsal, again, that dorsal corner, especially again involving the lunate area, the lunate facet area, the dorsal part of the lunate facet is a classical indication for your dorsal plate, where you have to just go in dorsally, pat that fragment back, and just use an L-shaped kind of a plate, a minimally invasive, low-profile kind of a plate. And that's all. You don't have to remove the distal tubercle. EPL won't come in the way. Just have to push it there, and it will hold it. Your volar plate screws really might not hold on to that, especially if it's comminuted.
Okay.
So in your, can I?
Yes, please.
Yes.
Your practice, what's the role which has been left for external fixator and K-wire fixation?
It's plate, then K-wires, then external fixator. I've not used it, to be frank, I've not used external fixator for probably many years now. So almost given up. K-wires we still use a lot. And sometimes I always use, again, with a combination with plate. It still serves a lot of purpose. So I sometimes start with K-wires and I might end with K-wires with a plate in between. But and extra-articular fracture is unstable, which means that there is osteoporotic bone, comminution is there. And the old patient who is not, I know that putting a cast might be difficult for them. I want to mobilize them. I still use Kapanji's technique. So K-wires still have their major role, and also bail you out in a lot of these intra-articular fractures also. External fixators, we have kind of given up, to be frank.
That's my experience as well.
Yeah.
One question, Dr. Anil.
Yes, sir.
May I?
Yeah, please.
A very comprehensive talk. I must congratulate you. You did not miss a single component, neither in inventory nor in the classification. A very comprehensive approach that we have to look for every aspect of the fracture personality. You have fixed the DRUJ from the ulnar, the wire from ulnar to radius, that is above the styloid notch. Do you always fix it above the styloid notch, or it's just convenience? Because in that case there was a lunate segment.
When you say above the ulnar styloid, I mean ulnar styloid notch, you're meaning that I'm proximal to the distal radial joint.
Proximal to the distal, yeah.
Yes, always. We never go through the DRUJ. I don't like to put wire through the DRUJ. It's always just proximal to that. So just at the proximal end of the sigmoid notch is where my wire goes. And see, I would have been, the patient would be in supination. I mean, on the hand table, and the limb will be in supination. Correct? When we do the volar, so it's much easier for me to put a wire through the ulnar side, because I can feel the ulna nicely. And I know that there is the radius which is fractured, so there could be fragments there. So I get a nice bite from the ulnar side, and I enter through the ulna always, and it's always just proximal to the distal radioulnar joint.
Yeah,
We don't want the wires to go
we
through
always
the,
that way you always save the lower fragmented part. It's always in the solid part.
Correct.
So
And
basically, the principle is just like the syndesmotic screw for the ankle. We always go above the syndesmos.
Correct. And most of the time, as the question was asked in the beginning, the joint generally nicely reduces in supination. So the hand is like this, and so it's easy for us to put the wire also. Yeah.
And we can put the above elbow back slab also, the plaster also in the same position.
In the same position, yeah.
And one more tip I would like to add here is it's almost as a precaution, you could make it 4 cortices. You can have a tip of the wire, protruding from the radius a little bit. So in case there is a breakage, don't waste any time. You can make a small incision on the radial side and fish out the wire. So that is one more important thing.
I want to ask you, how often do you need to fix the ulnar styloid process?
Whenever I see them, really displaced, and it's a big chunk, and it's quite unstable, I would like to fix it. And a basic precaution is that we never fix it percutaneously. We always open, make a short incision there. The dorsal sensory branch is retracted because it's an avulsion fracture, so it's never easy to reduce it back. And so we just have to open it, a mini open incision, get that, hold it with a towel clip or any other kind of this one instrument, and then put in a wire. The moment you fix that ulnar styloid, the joint really becomes quite stable. So when the joint is really unstable, wobbly at the end of your radius fixation, and you know that your DRUJ fixation wire might not really help, I would definitely want to do that. And especially it's a base fracture and it's quite displaced.
Thank you.
Ajit, can we take up another lecture now?
Yes, please. Yes. Thank you, Anil sir.
Thank you so much.
So our next talk is by Dr. Pankaj Jindal sir. Pankaj Jindal sir is a senior hand surgeon. He's a consultant in Ratna Hospital in Pune. He's very well trained orthopedic fellowship trained orthopedic surgeon who is from the Louisville and the different part of the Europe. Sir has described, that described so many techniques for the surgical techniques. So, and sir has a huge experience of around 30 years of huge experience of in hand surgery. We are really privileged that today we have Pankaj Jindal sir for this lecture. So he's going to talk on the scaphoid fracture, which is current standard of the management. The scaphoid fracture is that kind of fracture which is most of the orthopedic surgeons have always feared to know that how to do is, and always have a fear that is it going to unite or not unite, what to do, when to do, how to do is always the issue with the dilemma in the orthopedic surgeon's mind. So to clear all these doubts, today we have Dr. Pankaj Jindal sir. So Pankaj sir, please start your talk, please.
Thank you, Ajit. Good evening. Thank you, Dr. Dhawan. Thank you, UP Orthopedic Association. Can you see my slides?
Yes, sir.
Okay. So we'll talk about scaphoid fracture here. And a few things that I'm going to talk is how not to miss a fracture, because that's the beginning of the end. How to get an X-ray, how not to do an X-ray, and a small word about the classification, how to treat it, how to treat non-union, the role of vascular graft, and recent advances if time permits. So there's a lot of things written about the scaphoid fracture, and most of the things I picked up from the monograph which came last year here. The problem with the scaphoid fracture is the pain is not much, the swelling is not much, and the X-rays you often don't see anything. So let's take this example, a lady who had a fall on outstretched hand, an X-ray PA and lateral bow obtained, and she had a scaphoid fracture. Is it? No, it doesn't show anything. Obviously, what we see here is the fracture, the tip of the styloid process of the ulna. And sure enough, the diagnosis of the fracture of the ulnar styloid process with a sprain. And how do you treat it? You treat it with a crepe bandage. But she had a persistent pain here till we repeat an X-ray, and we see on the same patient the next morning a fracture of the scaphoid here. So what was the difference? We'll come to that in a little while here. what is the difference between the two X-rays. But let's come to the problem. Because the swelling is not much, because the pain is not much, patients do not seek treatment. They say doctors are unnecessarily treating. And doctors, I would miss it probably because I didn't take an X-ray as is a specific for the scaphoid. So to have a good diagnosis, you have to have a strong index of suspicion, which is a key to have an early diagnosis. So when do you have a suspicion? It is based on the history and the geography. What is the history? I'll talk to you. What is the geography? I'll talk to you. It consists of clinical examination and the X-ray here. So if you have a patient who has a fallen outstretched hand, that's the first mechanism of injury. So history of fallen outstretched hand and a clinical suspicion of tenderness. This tenderness is very specific. It is not just wrist tenderness. It's not very vague. It is very specific. These combination of a fallen outstretched hand and a very specific location of tenderness is to be treated as a clinical fracture of the scaphoid here. So what is the location of this tenderness? Anatomical snuff box, posteriorly, tubercle of the scaphoid anteriorly, or on axial pressure. If you have all these three tests together, never in isolation with a localized whatever little minimum swelling if you have a combination of these things, it should be clinically diagnosed as a fracture of the scaphoid here. So anatomical snuff box, axial load, and tubercle tenderness is a clinical diagnosis here. Then you get an X-ray. How do you do and what do you do? It is definitely not an AP and lateral. It is definitely not PA and lateral. It is something very different. And what is that very different? It is PA in ulnar deviation of the wrist, PA in ulnar deviation of the wrist with the fist closed. Why? I'll talk to you in a little while here. The next view that you'll ask for is PA in ulnar deviation with 30-degree tube tilt here and 30-degree pronated. It is difficult to remember pronated or supinated. Just remember pen holding position, pen holding position. So ask your radiographer to have a pen holding position. The hand automatically goes into a pen holding position and lateral view. So if you have these four views, you will be able to clinch the diagnosis of a fracture of the scaphoid. So ulnar deviation here, clenched fist view here. This is how the wrist goes into ulnar deviation here. Now when you're taking an X-ray of the wrist, the shoulder is abducted, elbow is flexed, and the whole forearm is resting on the cassette. It is not the X-ray of the forearm that you're taking, but when you have the whole forearm on the X-ray, you have a better delineation of the fracture here. That's the next view. 30-degree tube. The patient remains stationary. The shoulder is abducted. Wrist is ulnar deviation, but take a 30-degree tube tilt here and shoot. This beam is going into the first web space over the scaphoid here. So what happens when you have these X-rays? In a normal course, the scaphoid is a tilted bone here. But the moment wrist goes into a ulnar deviation, the scaphoid becomes a horizontal bone. So in the oblique view here, when the scaphoid is tilted, the fracture may be superimposed and you'll miss it. So the moment wrist goes into ulnar deviation, the fracture can be easily seen because the bone has become horizontal here. So coming back to the first case that I had shared with you, this was a PA and lateral view. The moment you take a ulnar deviation of the wrist, you see the fracture here. The second thing, do you have any fracture here? No. Do you need anything on the metacarpals? No. So what you need is a magnified view of the scaphoid. So if you have a localized tenderness, you are looking at scaphoid, you ask for a magnified ulnar deviation closed fist view of the scaphoid, and you'll be able to clinch the diagnosis majority of times here. So if you have a clinical diagnosis, but the X-ray is normal, the possibility of still having a fracture is still high, then counsel the patient. Tell the patient, look, boss, you still have a possibility of a late discovery of fracture. You might end up a non-union if you are discovered to have a fracture late. You better restrict your activity, and the best way to restrict your activity is to have a plaster on. So I'm going to splint you meanwhile, and I'll review your X-ray for 2 weeks and investigate again after 2 weeks. Some patients may accept your decision, others may not. And these are the patients who may require some other investigations. What are those investigations? MRI, CT, and ultrasound. And therefore, of all the three modalities of imaging, the best is MRI. You get an MRI, and the second best treatment after an X-ray to assess the possibility of a fracture if the X-ray is negative. What about the other modalities of MRI, CT, and USG? USG is largely operator dependent. So unless you have exceptionally good musculoskeletal sonologists, majority of people do not resort to ultrasonography. MRI to pick up a diagnosis if X-ray is not telling you anything, and you will require a CT if you have picked up on the plain X-ray, but now you have to plan. You have to see whether the patient has comminution, whether you have to see whether the patient has angulation, then you will require a CT. So you require an MRI if the X-ray is normal. You require a CT if the X-ray is shown the fracture, but you need to have further topography of the fracture, whether you see whether it is comminuted, whether it is angulated here. What is that angulation? I'll talk to you in a little while here. There are various classifications that are available. What they basically are looking at is the fracture is stable or it is unstable here. A stable fracture would mean the fracture is in the distal pole, or it is an incomplete fracture of the waist, or it is an oblique fracture, or it is a complete fracture, or it is a proximal pole fracture, or it is the scaphoid perilunate fracture here. So having made a diagnosis, having seen where exactly it is lying, you plan the treatment, whether you treat it operatively or you treat it with surgery here. Who are the patients who are a good candidate for non-operative management? The ideal candidate is the fracture is undisplaced, fracture is in the distal third, fracture is in the middle third, and the patient is willing to undergo a treatment without surgery. So patient can be managed. The majority of time the patient will be in the distal two-third and who are willing to undergo non-operative management here. The further indication will be patient can tolerate a below elbow plaster for 6 weeks or more than 6 weeks. That is important. 6 weeks or more than 6 weeks, and is still willing to go back to work, and he is unwilling for surgery here. Whether to immobilize the thumb or not, statistics say do not include the thumb and do not immobilize the thumb, but I do. Somebody said nicely, give Indians freedom, he'll take a lot of freedom. So he'll start driving motorcycle. He's going to hoist his motorcycle on the stand and cause distraction the fracture site, and he's going to bring bad name to you. And therefore, include the thumb for all our population, because they are going to misuse the thumb if it is not immobilized here. And further, if you treat them nicely in a snugly fitting cast, 90% of these patients in the mid third or distal third are going to end up in a union, provided the plaster is not broken and they have not misused their hand here. How long? Watson in 1955, before I was born, he said till the union. This is impractical. So a good rationale will be 6 to 8 weeks of casting in 90% of the patient. After 8 weeks, you remove the plaster and take an X-ray. If you on the X-ray it shows a gap, you take a CT scan. If it says the gap is confirmed, the union is not occurred, you fix them. If there is no gap, but is still tender at the age of 8 weeks, you splint it for another 2 weeks here. It has been compared whether to cast or to operate these patients. The negative thing that have been said about the cast is, oh, prolonged immobilization, it causes stiffness, but that's a short-term problem. They say grip strength reduced, but again, that's a short-term problem. Absent from work, the patient don't want to work, even if you operate, is not going to work. But the good thing that have been said about the surgery is short and he can go back to work here. But the fact is, the midterm results 6 months down the line, 3 months down the line, there is no difference here. So whether to operate or not to operate, the most important thing is the patient has to participate in the decision making. You do not impose whether to cast or operate. Tell the patient what are the advantages and disadvantages of both the techniques here. Having talked of non-operative management and who are the patients who do not require surgery, what are the indications for surgery? If the fracture of the scaphoid is displaced, he requires surgery here. If it is a fracture of the scaphoid with associated ligamentous injury, which is called as scaphoid perilunate ligament injury, he is a candidate for surgery here. With a fracture of the proximal pole here, he requires surgery. If the fracture of the scaphoid is comminuted, he requires surgery. Or there are multiple carpal bones and radius bone which are fractured, he requires surgery. He requires surgery because if you cast them, it becomes very stiff here. And therefore, operate both these bones and mobilize this wrist early here. Now, why you want to operate and what you want to achieve? What you want to achieve is if the fracture has fracture of the scaphoid has occurred, if it is collapsing, it is wedging, there's more of bone loss in the volar aspect, it is going to have a hump back. It is going to have a hump back here, and therefore it will have angulation. You do not want this angulation. Further, if it is not angulation, it might collapse. So why you want to operate? You want to operate because you want to restore the height and you do not want to have an angulation. And that is the indication and goal of our surgery here. The next indication for surgery is if the patient is presented late. These are the patients who are likely to end up with a non-union and a delayed union and a malunion. They require surgery here. What are the indications for surgery? The patient is presented 6 months down the line, 1 month, 1 year down the line, he requires surgery. Or if the patient, both the hands are affected, then personal care becomes very difficult. And these are the patients who at least one hand needs to be operated upon. Let's talk about the distal pole. This has a robust blood supply, and therefore the chances of it going into union is extremely high, provided you treat it. So they are generally treated non-operatively, and you give them a plaster for 6 to 8 weeks. But you do give plaster for 6 to 8 weeks. If you do not immobilize these fractures, they can also go into painful non-union. And therefore, distal pole can be treated majority of times without surgery here. The problem is with the proximal pole because this is an unstable area here, and they invariably require surgery because the vascularity is one thing is poor, because they are held on to lunate and they move with the lunate, and therefore possibility of ending in a non-union is extremely high. So proximal pole, always surgery. Distal pole, majority of times, no surgery is required here. So coming back to the waist here, whether to cast or operate, the decision is based on what the patient ultimately wants, depending on his job profile here. How do you fix them? There are various options which are available. Of them, the one that are commonly used are the screw fixation or cannulated K-wires fixation. So K-wires or screw fixation, the currently available screws are the cannulated screws, which are very much in vogue. Plates have also been used, and even Ilizarov technique have been utilized for treatment of acute fracture of the scaphoid here. Just a word about fracture the scaphoid in the plating. Yes, plating has been done. This is a 0.8 millimeter plate fixed on the volar aspect here, and this is a 1.5 millimeter plate. This is a second patient. This is not my patient. I borrowed it from some of the books here. How do you fix it? Whether to fix it dorsally or volar? If the fracture is in the mid third, it is surgeon's preference. But important thing is it is a meticulous technique. If you are doing it a volar aspect, you repair the ligaments nicely. Otherwise, you are possibly going to end up into instability here. If it is a more fracture, is the proximal pole is smaller, you go dorsal. Otherwise, either way is good enough. It is very important to know how not to do it. Just see how the wire is fixing only very small fragment of the distal pole here. It would have been worthwhile fixing it from further distal so that you can have an adequate purchase, because what you see here is a rounding of the edges here because this was inadequate hold of the wires here, and it ended up in a non-union here. Let's take a few clinical example. Bilateral fracture has an exam in a following week here, and therefore one hand had to be operated, though it's an undisplaced fracture here. On the patient here, fracture the scaphoid here, displaced, and therefore this required to be open reduction, internal fixation. This girl had a fracture the distal end of the radius here, and I don't see anything in the scaphoid here. So I operated again another view here. Scaphoid looks normal, but the radius is fractured here. So I operated a radius, and scaphoid doesn't show anything here till subsequent X-ray started showing something here and some fracture here. Therefore, this was a patient who had a late diagnosis, and these patients again become a candidate for surgery. Further, fractures of the adjacent bone is another indication for surgery of the scaphoid here. So we operated this girl as a secondary setting because there was a late diagnosis of scaphoid fracture here. The next indication is a transscaphoid perilunate fracture dislocation here. So this patient had a fracture dislocation. She was a girl here. She was a doctor here, gynecologist. Fracture here, no fracture here. This is a perilunate dislocation here. Lunate is out. Fracture of the scaphoid here, and we did a perilunate fracture dislocation. We reduced the scaphoid and fixed it with multiple K wires and did a treatment of a perilunate dislocation here. If both the bones, the radius and scaphoid, are fractured, then immobilizing for a prolonged period is going to give to a lot of stiffness. These needs to be operated. Next patient is the indication is a fracture of the scaphoid with comminution here. If it is comminuted, then you put a bone graft and fix it with screws here. This is another patient who had a proximal pole fracture here. Again, whether you fix it with the K wires or screws, depending on whether you have adequate space available for putting a screw here. So you have options between screws and K wires versus plates versus screws. Implants, choice of K wires versus plates. One paper said screws are better. Other paper said it doesn't really make a difference. So depends on again the choice of the surgeon, what he really wants, screws or K wires here. Coming to the non-union of the scaphoid, what is non-union? Absence of radiological union at 12 weeks at 3 months and a clear gap on a CT scan across the whole diameter of this bone is a non-union here. And why it occurs? It occurs because of delay in diagnosis, inadequate treatment. Inadequate treatment, you have a plaster for 3 weeks, 4 weeks and say, okay, mobilize it. That's not absolutely acceptable. The plaster has to be minimum 6 weeks. At 6 weeks, if it is still tender, then you immobilize further. If it is displaced, there is associated ligament injuries, or there is a possibility of avascular necrosis. There's a non-union here. Why treatment? It may be why you should treat this thing, because it's initially painless. Ultimately, it becomes arthritic and it is likely to become painful ultimately, and therefore do not accept a painless non-union. Offer them surgery as soon as it's possible here. And this progression of arthritis is very progressive and systematic. Initially, once you have a fracture, there might be osteophyte formation of the styloid process. Then it affects the joint between the scaphoid and the capitate. Then it affects the joint between the capitate and the dulent, and then affects all the joints here. And this is called as the snack wrist or scaphoid non-union advanced collapse. And they again has to be stopped as soon as the patient report to you. So otherwise, it is going to become pan wrist arthritis and painful here. How do you treat them? Non-surgically, if the patient is unfit for surgery, you cast them for 6 months if it is practically feasible. Otherwise, they require a bone graft and internal fixation here. There are various kinds of bone grafts available and recommended. If it is just collapsed, you put a bone graft after debridement of the bone edges. If it is angulated, as seen on CT scan, you need a wedge or a vascular bone graft here. But again, this is changing the role of vascular bone graft. We put a lot of bone graft, probably a decade back, but now probably in the last 3 years, we have put less and less of vascular bone graft. Coming back to painless non-union, do not accept a painless non-union. Debride these edges, remove this bone, remove this extra bone formation, and treat this fracture nicely here. Another patient with a kissing lesion here, a non-union here, remove this bump here, remove this bump here, and fix it with a bone grafting here. What about vascular bone grafting here? Large number of proximal poles required a vascular bone graft here, and especially the previously failed mid-third also. And what that basically meant was taking out a chunk of bone from the, usually from the dorsal aspect, taking out a chunk of bone and putting it into the scaphoid here. So this was the patient with a proximal pole. We took out a vascular bone graft and fixed it with the screws here. Other patient with a non-union proximal pole here. We took our took a bone piece from here, vascular bone, and fixed it here. But this is the most important thing that we have learned in last 3-4 years. Success of scaphoid non-union surgery is independent of proximal pole vascularity. And what that basically meant, the study was of 35 patients, and they assessed the viability based on the pre-op MRI, intra-op bleeding point, and histopathology examination of proximal pole bone. And what they found in the preoperative bone, 9 of these bones was ischemic on MRI, 28 intraoperatively had a reduced bleeding, and histopathological examination, 24 bones showed they were necrotic. And what happened to these bad bones? 33 of these bones went on to union at 12 weeks with conventional bone grafting. That means the vascular bone grafting has been an overkill. And they concluded that proximal pole infarction is rare and that vascularized bone graft is seldom required. And there's a whole article on this. I'll not go into that. Another paradigm shift has been in articles in 85 and 17. David Green in 85 said, in avascular bone, they tried 5 times and it went into non-union. They said, no, useless. In 2017, they said, if you put a bone graft and immobilize with internal fixation, it's going to go on to union. And it is not the vascularity of the bone. It is not the kind of bone graft that you are. It is the conventional bone graft with internal fixation that these have gone on to a union here. Then there are cases of painful arthritis. And what do you do? If they still go on to non-union and still has an arthritic changes, then you excise the proximal pole and you do a proximal pole carpectomy versus some kind of fusion here. I have not done any of these things. They are again borrowed from the books. I have been extremely happy in the last 30 years with proximal low carpectomy. It really works nicely. Yes, you might lose about 40 to 50% of your range of motion, but remains painless in almost all the patients here. One patient who occasionally complained was a heavy-duty laborer employed in Middle East, but otherwise these patients do extremely well with a proximal row carpectomy. What about silicone implants? Absolutely no. These are historical. Do not put silicone implants there here. So in summary, clinical diagnosis, snuff box tenderness, axial load, tubercle tenderness. If at all, take an X-ray, PA and ulnar deviation or 30-degree tube tilt or pen holding position here. Immobilize for 2 weeks if clinically suspicious, but the X-ray is normal. If patient is affording, get an MRI done. Conserve is stable distal pole or mid-third here. You have a choice of screw versus K-wires. Proximal pole, put a bone graft and fix it here. I thank you very much for patient listening.
Thank you, sir. It was a splendid talk, sir. Really amazing. You have covered all the part of scaphoid fracture. So I have one question. So if some patient has a scaphoid fracture with some displacement and you want to do the fixation of the fracture, so what is your upper limit of the time when you want to do the percutaneous fixations and when you want to do the open reduction and the bone grafting?
I'll try once. If not, I don't want unnecessary radiation. And I'll open it, fix it. I'll quote David Green. He was in India about 10 years back. He said, my residents tell me, Doc, look how nicely I fixed. I've done it percutaneous. I say, yeah, I can see you are glowing. You're glowing with radiation. So I don't want unnecessary radiation for myself or patient. I'll try once. If not, I'll open it. Anything, whether there is a phalangeal fracture also.
Okay, sir. So Dr. Unmesh is asking, what is the choice of bone graft in non-unions of the scaphoid? Means that what is the donor site from where you harvest the bone graft?
Majority of times, we are able to harvest bone from the distal radius. But what is the most important thing? You should be able to debride the fracture site and put a lot of bone graft. If you have a big cavity there and you feel that cavity is too big and you will not be able to have so much of bone graft, go to iliac crest.
Okay.
The union fails because you have inadequately packed it with the bone graft. And the amount of bone graft you can get from distal radius is very limited. So if you feel the cavity is small, after debridement, after freshening the edges, you feel the bone graft will be adequate from the distal radius, that's the first choice. But if the cavity is too big, I'll take it from the iliac crest.
Okay, so it's just because of the amount of the graft, or you want to put the tricortical or the cancellous bone graft? What is the preference?
Oh, okay. So, yeah, fine. So if it is a big cavity, it has collapsed significantly, and now you have to distract it and put a big bone graft. tricortical, then you, of course, you'll go to the iliac crest.
So one question from Dr. Anil Singh. Have you seen fracture scaphoid in the children, and what is the definitive management for that?
We have seen occasionally, offhand I remember two, and we treated them conservatively and they went on to union.
So,
I have not seen delayed presentation years later non-union. So maybe I'm still young, so another 30 years of practice.
So Dr. Imran is asking how much assurance of union should be given after internal fixation in both fresh and old scaphoid fractures?
I'm sorry, say it again, please.
How much assurance of the union should be given after internal fixation in both fresh and old fracture of old scaphoid fracture to the patients?
How much? What aspiration?
Assurance. How much
assurance? Oh,
yeah,
assurance. Oh, no assurance. Absolutely. You say I am going to do. What assurance I can give you is I am going to operate, and I can give you 100% guarantee that I am going to operate. I can guarantee. Everybody in our country wants guarantee.
Correct.
So what I say, yes, I guarantee you surgery will be successful, but I don't guarantee the results. So you have to start choosing the words. Yes, I guarantee I'm going to operate. I guarantee my junior is not going to operate. I guarantee my driver is not going to operate. I guarantee the surgery will be successful, but I don't guarantee the results.
So I think already you have told that Dr. Unmesh is asking that should we mobilize for fixation both in fresh and old cases? Yes, of course.
Yes.
Pankaj, Santosh here.
Hi.
Yeah, Santosh sir, please.
Yes, although you have described everything so nicely that nothing is discussed here, but I am just asking, suppose a young surgeon want to operate on a scaphoid fracture, and this was an undisplaced fracture, you applied a plaster. Then how early you can decide if this patient will go into the non-union, or I will decide how early I can decide when you go for operation this patient?
Okay, so you still have, if you have treated it, you have planned to treat it conservatively, a displaced fracture. The problem is the malunion. The malunion 6 years to 7 years down the line is going to become painful. And we are dealing our problems. 6 years down the line, patient comes to your doctor, I got treated with you and now it has become painful. And coming from WhatsApp University and Google University, they said, doctor, this was a displaced fracture. How come you treated it conservatively? I can see a displacement there. And then it becomes embarrassing. We are dealing problem. And therefore, if you have something, we should be able to answer it, why we are operating and why we are not operating. So coming back to your question, 6 weeks to 7 weeks is a immobilization time. At 6 weeks, if it is there's a gap on CT scan, he requires surgery. At 6 weeks, if there is no gap on CT scan, but it is tender, I'll immobilize for another 4 weeks.
I think, thank you, Pankaj sir. It was very delighting talk.
Thank you.
You explained all the doubt, you have cleared all the doubts. So I think we'll move for our next talk. So our next speaker is Dr. Ravi Bharadwaj sir. So Ravi Bharadwaj sir is working in Apollo Hospital, Kolkata. He's a senior hand surgeon there, and he's trained from Royal College of the Surgeons from Edinburgh. He's very experienced, as well as he's excellent surgeons. We always love to see his videos. Most of the time he shares his videos on the ISSH group, and amazing videos he make and amazing surgeries he does. So he's going to talk on the Kinbox disease. As the scaphoid we have discussed, the next talk is on the Kinbox disease. Kinbox disease is basically the avascular necrosis of lunate. So it's unfortunately, this problem happens to the young childs in the second and third decades, where the patient has young patients, and it's always dilemma that what to do, how to do. And so the next talk is on the demystifying on the disease. So Ravi sir, you're most welcome. You can start it off, please.
Thank you very much, Ajit. Is my screen visible?
Yes, sir, very much.
Okay. Thank you very much for the invitation. It's an honor and a privilege. My brief today is to talk on Kinbox disease. So all of this, as orthopedic surgeons, encounter this not infrequently in the practice, day-to-day practice, but many of us are at times confused because of we have been trained in a certain way, and maybe we have only one or two surgeries which we have been trained to do. But the whole spectrum of Kienbock's disease is a little bit confusing in itself. And over the next few slides, my job is to try and simplify things and bring in the rationally between the decision making in various stages of the disease, what has involved in the last few years, because a lot has changed. So Robert Kienbock, who was an Austrian radiologist, was the first person to describe this, which bears his name, and he described it in 1910 as a lunatomalacia, or softening of the lunate, but he attributed it to malnutrition rather than anything else. We all now know that it is an avascular necrosis of the lunate. And just a quick recap, symptoms usually tend to be dorsal central wrist pain, which is often activity related, occurs usually in the dominant hand. In a very small subset, bilateral cases have also been reported. And in terms of physical examination, there is often tenderness over the radiocarpal joint and palpation varying degrees, and sometimes there's a decreased range of movement and a decreased grip strength also. So there are various theories regarding the causation of this. We'll briefly, to understand this better, we'll just briefly go over the common causes. So repetitive trauma has been postulated as one. This is because of repetitive movements causing the lunate to impact against the dorsal edge of the radius and cause microtrauma and localized, affection of the blood supply. Negative ulnar variance increases the contact stresses and the loading. Here you can see that a lot, because of the negative ulnar variance, the large part of the lunate has been unsupported here, and that transfers the contract stress to the radial side, and this has been sort of thought to cause Kienbock's disease. Another theory is the inclination of the radius. So a decreased radial inclination is also thought to be causative in increasing the contact stresses and thereby affecting the vascularity. Lunate geometry has been described also as a causative factor. We have Viga's theory of type 1 and type 2 lunates, and then more recently Zapico has come up with their classification. I'll just briefly go through it. So they have described three types of lunates. So one, this is the scaphoid articulation, and this is with the radiolunate articulation here. So the angle which is made between these two, if it's 130 degrees or more, that's type 1. In type 2, it's between 110 to 90 degrees, and type 3, there are two different facets for the radiolunate articulation. And it has been shown that the type 1 Zapico lunate morphology is more associated with Kienbock's disease. This is just an observation. Vascular theory has also been often alluded to, and this two theories have been talked about, the arterial and the venous theory. So the arterial supply talks about different types of vascular patterns, and the microvascular anatomy of the lunate has been studied in detail by various workers. So they have described three different patterns: the Y pattern, which is the commonest, which is 59%. They talk of a I pattern, which is about 31%, and 10% of an X pattern. And not surprisingly, the I pattern, because is the most affected lunates have the I pattern on histopathology, and this is because they're vascularized, compromised inherently. Now, Greg Bain has come up with this theory, and they have very interesting theory. It's almost similar to AVN, which we commonly encounter, and we talk about idiopathic AVN, where there is a, it's like an intraosseous compartment syndrome. So the venous outflow is also obstructed. So this is one exciting theory. It's somewhat akin to a intraosseous compartment syndrome. So this one is the arterial blockage. This one is the venous outflow blockage. And here you could have, obstruction of the microvascular by thrombi or emboli, whatever. And you could have external tamponade. So any of these four factors could cause the lunate to become avascular, and venous outflow is now thought of as an intraosseous compartment syndrome, very much similar to what we talk about in AVN of the femoral head. So Lichman's classification is based on the PA and lateral views, and this is most commonly used. So the conventional classification is the stage 1, where you have a normal X-ray; stage 2, where you have lunate sclerosis without collapse; stage 3A, when the lunate shows signs of collapse but there is no scaphoid rotation; 3B, when there is scaphoid rotation; and 4, when secondary degenerative changes. Now 3B in addition has a more recent 3C addition, where there is a coronal fracture of the lunate which has been added. So Lichman 3C has been added, and more recently a stage 0, which is akin to a AVN of a femoral neck where there are no symptoms, say femoral head AVN. So similar asymptomatic stage 0 has also been talked about in literature. So what is the dilemma we face as orthopedic surgeons? We often see that the symptoms don't always correspond to the stage on X-ray. The disease behavior varies from person to person. More often, at the extremes of age, in children and elderly, it takes a sort of a rather benevolent kind of course of action, slow. Unfortunately, there are no uniform guidelines, and we are all dictated by what we trained with. We seen our bosses do something for a particular condition in lunate, so we do that for all the cases we see. And there are multiple procedures described in literature. One cannot be a master of all of them. So we usually train ourselves in 1 or 2 procedures, and irrespective of what is the causative, pathology, we stick to those procedures, and we don't feel, courageous enough to venture beyond what we are safe doing. That might not necessarily be the right thing. So let us talk about the underlying principles of what is the generally accepted procedures for Kienbock's disease. So basically, there is a category called lunate unloading, where you unload the stress on the lunate. You could put an X-fix and distract the joint, or you could do joint leveling. For example, if there's a ulnar negative variance, you could shorten the radius or lengthen the ulnar, or change the inclination of the distal radius. So that is one possibility. You could decompress the lunate, because just like core decompression of the femoral head for AVN, you could try something like that, drilling. You could do procedures to revascularize the lunate, like bone grafting alone in isolation, or you could do a pedicle bone graft based on the vascular pedicle from the arteries around the distal radius, or you can do a free vascularized bone graft. If the lunate is unreconstructable, you could consider either an excision or replacement. Replacement not readily available in our country, but sometimes, pyrocarbon implants and all these things have been discussed in literature. We'll come to that in the later slides. If the central column is compromised, because the lunate is the inherent part of the central column, then basically the philosophy of treatment is to either fuse it or to bypass it by adopting some sort of limited carpal fusion, like you would do a radioscapholunate fusion or a scaphocapitate fusion. If the carpus has collapsed, you could try a scaphocapitate fusion or a limited STT fusion, scaphotrapezio-trapezoid fusion. And if it is a pancarpal arthritis and the wrist is not reconstructible, it's quite advanced, then arthrodesis seems to be the most, practical option in our solution. In our situation, we are not very, arthroplasty of the wrist is not very popular in our country, and this is probably not the right thing for this. It's only a different subset of patients. So let's talk about stage 1 and stage 2. Lunate unloading procedures. You could distract the joint with an X-fix, is the simplest, and that too will reduce the stress on the lunate here. You could try a limited pinning of the wrist temporarily, to reduce the stress on the lunate, and you could do a STT pinning for a few weeks and then take the pins out, and that way, you could reduce the contact stresses on the lunate and hope that it regains its vascularity. And if there is a situation where you have a negative ulnar variance, then you could do either a radial shortening or a radial inclination correction. The other thing which you could do is a capitate shortening osteotomy. So let's take some pictures. This is just a schematic diagram of a radial shortening and ulnar lengthening. So most commonly, radial shortening is much more easier. Ulnar lengthening is not commonly done. Again, capitate shortening has been described. You just remove a couple of millimeters of wedge from the capitate and fix it with wires or a headless compression screw, and that reduces the contact stresses between the capitolunate articulation. So for stage 1, 2, and 3A Lichman, you could use revascularization procedures, like you could drill the lunate and bone graft it. Simple act of distal curettage or foraging, just drill the distal radius and curettage from the metaphyseal region, is said to increase the locus vascularity and secondly increase the blood supply to lunate. That has also been described. More often than not, you could do a vascularized pedicle bone graft based on the 4-5 ECA, or a free vascular bone graft using microvascular anastomosis, and this is usually taken from the medial femoral condyle. So this is a picture. This is one of the cases which I had done for someone from the Middle East. So this is a vascularized bone graft based on the 4-5 ECA, and this I put 2 scaphocapitate wires to protect the graft while it incorporates, and you protect it with a plaster for at least 6 weeks. Stage 3B, this is where the collapse has occurred and the scaphoid is in fixed rotation, and there is usually capitate migration proximally, and there is diminished carpal height. Here, revascularization procedures are less likely to be effective, so it's too far gone. So in this kind of situation, you only look at salvage options in stage 3B and 4 usually, and the indicated procedures are either you could do excision of the lunate and an STT fusion, or lunate excision with scaphocapitate fusion, lunate excision with lunate prosthesis, or you could do an entire proximal row carpectomy. This is a different indication, but again very effective, like Pankaj sir has already talked about in scaphoid non-unions. Or if it is very extensive and all the joints around the wrist are involved, then a salvage procedure like wrist arthrodesis is probably the rational option. So let's talk about lunate excision and scaphocapitate fusion. This is usually indicated in young active patients, and the aim is it corrects the scaphoid malalignment and stabilizes the mid carpus. Also, that's very important. And because it maintains the height of the carpus, it prevents the further collapse which occurs, when you remove the lunate. So this is a intraoperative picture. You can see that the lunate has been removed. The scaphoid has been restored to its normal rotation, and to fix it, we've made the area raw between the scaphoid and the capitate, and we've used two headless compression screws. This picture has been loaned to me by my good friend Dr. Anirban Chatterjee. So this is another X-ray of lunate excision and scaphoid trapezoid fusion. This is preoperatively. You can see the lunate has collapsed and the capitate has migrated proximally. Here the lunate has been excised and the STT joint has been fused with K wires. This is 2 weeks post-op, but this is again 6 years post-op. You can see that the gap is still maintained. There is no further collapse and the capitate is maintaining, and there is STT fusion here. So this also works. Proximal row carpectomy, Dr. Pankaj sir has already spoken about in his talk on scaphoid non-unions. This is usually in the scenario of lunate when it is advanced irreconstructible lunate or revascularization procedures are not feasible. You could do a proximal row carpectomy. Generally, these are reserved for low demand patients, and it can be combined with wrist denervation to give very predictable pain relief. And what happens, it transfers the load to the capitate, so the lunate is removed and the capitate, it takes its place here, and this is the articulation between the capitate and the radio and the lunate fossa fragment or fossa of the distal radius. It's a very effective procedure. And now I've said that it is only in low demand patients, but my good friend Dr. Praveen Bharadwaj has shown in a series from Ganga Hospital, they've shown it in younger patients and also in high demand patients with long-term follow-ups, and it seems to work quite well even in that subset of population. So stage 4, when it is a extensive arthritis involving the entire wrist, then arthrodesis seems to be the logical option. So whatever I've talked about, you might all say, well, why is he boring us with all this? We already know this. So what's the big problem then? The problem is in lunate, with Kienbock disease, there are a lot of unanswered questions. For example, there is an inconsistent response to treatment. So, how do you know which treatment is going to work for you in which stage of Kienbock? That is always a problem which confronts us, which sometimes we think, okay, negative variance, we are going to shorten the radius. Sometimes you go in and see there is no negative variance. Are you going to do a shortening? That is the only procedure you know. If you don't know that, what else are you going to do? What else can you offer the patient? Which procedure to do when? That is also a question. And there are so many unanswered questions. So in the light of all this, two good things which have happened to us is, in the last 10 or 15 years is more and more usage of two modalities. And these have been big game changers, especially not only in hand surgery, but specifically for Kienbock's disease. And one of them is the MRI, especially the 3 Tesla MRI, and the other one is the wrist arthroscopy. And a lot of things have changed, regarding the management of Kienbock's disease since we started using these two modalities more and more frequently. With regards to MRI, we know that it allows detection in an early stage, and it can offer a differential diagnosis. You can distinguish between ulnocarpal impaction syndrome. Here also you have a selective area of the lunate which is showing signal changes, but it is a completely different entity. It has ulnar positive variants, and whereas this is associated with ulnar negative. The findings in MRI usually you have a decreased signal intensity in T1 and shows a black lunate with diminished vascularity. And sometimes you don't always have this everywhere, but if you could have the option of using a 3 Tesla MRI with gadolinium contrast, it's usually very useful. But unfortunately, not all of us have access to this. When would you use a CT scan, and when is a CT scan helpful in lunate? Well, a CT scan is best for showing the extent of the necrosis. It can show trabecular dissection, and then it can show the morphology of the lunate and the facets, which I've already talked about in the with the type of lunate, whether it's a type 1, type 2, or type 3, the pico, etc. Now, this is a very game-changing sort of classification. It's actually about not very recent. It's about 10 to 15 years old. It's by Schmidt, and they used MRI and came up with their classification of lunate vascularity, and they also prognosticated based on this. Okay, so basically, they have. I won't go into the details. So they have looked at the patterns of vascularity of the lunate, and based on that, they have classified into normal A, B, and C, and they have given the prognosis, depending upon the vascularity on the MRI using gadolinium contrast, whether it is going to be a good, intermediate, or a poor prognosis with regards to lunate. And specifically, in order to make it a little bit simple, I'm just going through this complex slide. Just let us look at it. So basically, normal, which has a, there's no problem or nothing to worry. Ischemic pattern, which is MRI pattern A, where the prognosis is good. If there is partial necrosis, which is a MRI pattern B, and then that is intermediate prognosis. And when the bone is completely necrotic on MRI, which they've called MRI pattern C, then the prognosis is poor. And just getting this test before you even embark on surgery, and you can classify it based on the extent of necrosis, will help us prognosticate what could be the outcome and prognosis. And also, you won't waste time salvaging a lunate which is potentially unsalvageable. So you can, tailor make your procedure, based on the prognosis of the likely outcome. If you can predict it beforehand, you can choose your operative procedure accordingly. Now, another path-breaking sort of development in arthroscopy is the use of arthroscopy to do the classification, and a lot of work has been done by Professor Greg Bain from Adelaide, Australia. I met him about 4 or 5 years ago in Taiwan, and he was very excited. His book was about to come out, and he spoke very enthusiastically about this classification. The book is out now. It's been around for about 3 or 4 years now. And he talks about a very good classification based on the arthroscopic classification of the various non-functional surfaces. So he talks about these various stages. It's not very complicated as it seems to be. If you understand, it's very simple. So stage 0 is when all the surfaces between the capitate and the two proximal and the distal articular surface of the lunate and the distal radius are all normal. So there are 0 non-functional surfaces. In stage 1, there is only one non-functional surface, and that's usually the proximal lunate, which is, showing changes, of damage, softening, fibrillation, etc. Stage 2A, where you have the distal radius as well as the, proximal lunate, both showing changes of softening and, fibrillation, etc. And stage 2B, it is the proximal lunate as well as the distal lunate articular surface. In stage 3, similarly, it is both the distal radius, proximal lunate, and the distal lunate. And stage 4, you have almost all the 4 surfaces, so 4 non-functional surfaces. So you can see, as the arthroscopic classification, as you proceed from stage 1 to stage 4, the severity is also more, and the prognosis and the outcome also sort of becomes gradually more worse the more severe the stage, the higher the staging. Okay. So here is another sort of recommendation which Greg Bain has made on the basis of the arthroscopic findings. So he has mentioned the grade and here, and also the recommendation of the type of procedure which is likely to work based on the arthroscopic findings there. And the processes we have already talked about. I'll come back to it in a minute in another slide. So if you see, arthroscopy offers us a very unparalleled view of what's inside. And this is the lunate, which sort of in early stage, it looks a little bit, featuring in all. But here you can see lunate is significantly affected, and so is the radiocarpal articular surface. And in fact, you can use the probe to, even if the chondral damage is not very visible, you can use the probe as an extension of your finger and actually palpate the joint and see that it's been salvaged. So arthroscopy has actually revolutionized, not only diagnosis but also management, because in skilled hands, a lot of procedures can be done, arthroscopically with minimally invasive. So you could, in fact, remove the entire lunate and do, scaphoid reduction. This entire procedure can be done arthroscopically. Now, stage 3 and D, where you can do a vascular graft with the, medial femoral trochlea. You take a graft with a microvascular anastomosis. You can, do microvascular anastomosis and attempt to revascularize the lunate. And this has been described by Berger et al. In 2014. And this is also very exciting because it was a new prospect. I know it involves a lot of technical skills, but it can help, salvage reconstructible lunates. And a lot of work has been done by Bill Geisler from Texas, Austin. They have done a lot of pyrocarbon replacement, and there is a French model from Tournier and Ascension, another company from US. But the early first generation pyrocarbon implants were not very successful, and the jury is out on the second generation. This is done by a dorsal approach, and this is what it looks like. So it is claimed that the second generation are more anatomic and site specific, so better results. But the jury is out. We'll have to wait and see what the long-term results are. The intermediate results, the authors have claimed good results. So let's talk about the future of the skin box surgery, and this is where we sum up and summarize whatever we've discussed. So basically, if you mix and take into account everything which we have discussed and talked about so far, so you have the Lichman classification based on X-ray, the vascular classification of Smith, the arthroscopic classification of Bain, and then with the description of the lunate, then basically if you combine everything, you get this master chart. It might look a little bit crowded, but if you look at it carefully, it's very simple because it just tells you basically that the higher the grading as you go down, the more likely are you to lead more salvage procedures, and whereas you can do unloading procedures in the earlier stages of disease. So this offers us a very useful working algorithm as to choose, based on your immediate. So, but the only thing is you just can't look at an X-ray and decide what you're going to do. It will be useful if you have these two tools in your armamentarium. I realize that it might not be available to everyone and everywhere, but this is again an ideal scenario. But that should not sort of discourage us from, not seeking, treatment. At least it opens us our mind, even if we don't do arthroscopy, or even if we don't have access to MRI, at least it opens us up to the possibility as these are the things which should be considered, especially in decision making. So this is what has been the game changer in decision making in Kienbock disease over the last few years. And in summary, what I would like to say is arthroscopy and MRI have vastly improved our understanding of the disease. And this has helped us in choosing the right procedure for the patient based on the demand, functional activity, and the stage of the disease. Many procedures now can be done with minimally invasive techniques. And, medial femoral condyle vascularized osteocartilage graft offers exciting possibilities for salvage, but pyrocarbon arthroplasty long-term follow-up is awaited. And for any of you who are more interested in delving deeper into this subject, I would recommend this. It's a fantastic book, a textbook by Gregory Bain for more reading, and we've covered this topic extensively. I thank you very much for your patient hearing.
Ajit, unmute yourself.
Ajit, unmute yourself. Again, unmute. You have muted again.
Yeah, thank you, Ravi sir. Thank you so much. It was wonderful talk. You have covered, I think, whole Kienbock's disease, all the aspect of the diagnosis management part. I have just one question, sir. I think we are already late, sir. So I have one question, sir. What is your preferred method of treatment if patient is stage two with the normal variance? There's no negative variance.
My biggest problem, and I'm sure it's, I'm sure like, Anil and, Pankaj sir would agree with me, is, we hardly get any patients very earlier on where, where the unit hasn't collapsed. Often, in our country where patients seek, they don't come to us primarily. They have already been here and there, or they've sat on their problem. And when it comes to us, when you see on X-ray, the lunate is already collapsed. It's very rarely you get to see someone where, you could do a stage 2A, 2, or even a 3A for that matter. So in that context, whenever I see a patient, I would obviously try and counsel them. The second thing is trying to sell them a surgery for a problem which you think might cause, problems in the future. They are not ready to buy it. And the first thing they will say is medicine se nahi hoga ya plaster se nahi hoga, kyun operation karna chahte ho? But if a patient is motivated and you can counsel them, obviously in the absence of negative ulnar variance or any mechanical factors, I would be going for a revascularization procedure. And I have preferred, a pedicle bone graft in the past, and it has worked quite well for me.
So,
Can I have a question, Ajit?
Yes, sir. Please go ahead.
In the same regard, Dr. Ravi, I would like to ask you. I think most of these patients who have a stage 2 disease, they do definitely have a pain in the wrist while working.
Yes.
The problem
Yes.
is in that most of the orthopedic surgeons do not give attention to that pain and get an MRI done, because that's the only way to diagnose them early. So it's not that patient do not have a problem. The problem is with us that we do not able to diagnose. So once we diagnose it, probably they'll be able to go for any sort of treatment which we wish to give them, because pain is really remarkable by that stage where their daily routine work is really hampered, especially female side.
Absolutely. And by this, I mean, having webinars like this, one should have a very high index of suspicion and a low threshold to get, we should not shy away from getting an MRI wherever we suspect it's something, because early intervention obviously will have a better result, rather than.
Thank you.
Dr.
So,
Ajit,
sir,
can I
if you have
question?
permission, can I go for the case
Dr.
presentation?
Ajit, can I have one question?
Yes, please, sir.
Dr. Ravi.
Yes, sir.
See, if there is a negative ulnar variance, then we have to go for the leveling procedures.
No, sir. If there is no negative variance, why would you level the joint? The joint is already level.
No. When there is a variance, ulnar variance, then you have to go for the leveling procedure, no?
Yes, if there is a ulnar variance negative, then you can go for this is one of the options.
So, in leveling procedure, which you prefer, radial shortening or ulnar lengthening?
The simplest thing is radial shortening, sir. That's what I would think, because with the anatomical plate, it's easy.
When there is ulnar variance is normal,
yes,
then which is the most commonly used procedure which you use when the ulnar variance is normal?
Very frankly, for that, there is a number of procedures which have been described. So it could be what your one's own training and comfort level is. You could simply go and drill the lunate and do simple packet with bone graft. That has also been done. But if you have a little bit more expertise, you might want to combine it, with a pedicle graft. And someone who is, a little bit over the top, it might seem, but someone who is very comfortable doing it might not want to take any chances and might feel more comfortable doing a, free graft, a microvascular graft. So it all depends. The principles remain the same. How you want to do it is based on, your own training. That even the textbooks and even the recommendations, they just mention the principles, but the exact technique is still, up to you.
Okay. But there is no more studies which are comparing the treatment. Somewhere I read that the capital shortening osteotomy with capitohematate fusion. This is the most commonly used procedure. What is your opinion regarding?
Capitate shortening, I mean, I think you cannot generalize, sir, because lunate is something like that. I would not say that in the absence of doing these two things which I've talked about, the arthroscopic examination before every surgery. I think that's a fantastic thing. So if I put in a scope and I see that there is no problem in the capital, in a capitate and the distal lunate articular surface, a capitate shortening osteotomy is not going to help me. So you have more objectivity to your decision and also more rationally if you just do a preoperative wrist arthroscopy. It will just put more confidence in the procedure which you're going to do.
Thank you. Thank you.
Great, sir. Dhawan sir, you want to ask something?
You go ahead with your talk. I think there's no more. There are no questions.
Okay. So I'll present two cases. They are very nice cases. There's one 28-year-old man. He is right hand dominant. He's basically UPSC aspirant. He was fall on outstretched hand injury, and there was injury to the right wrist, and he presented to me with the pain and deformity. And this was the X-ray. So, Anil sir.
Yeah, Ajit. A young patient, dominant hand, high energy kind of injury. That's what I see. And if you look at the lateral view, you see the lunate is with the dorsal fragment. It's kind of sliding away with a very bad dorsal tilt there, and the three components there. The radial styloid is a big chunk there, and there's a combination of that also. but the reasonably okay looking lunate facet, and there is some depression on the central aspect there with some void there on the lateral aspect. Yeah.
Great. So you want to do any further investigation, or is this okay for you?
Yeah, I would do a close reduction of this patient and then get a CT done.
Okay. So this is the CT scan, the axial view.
Yeah. So as I said, the dorsal part is the one which is more damaged here. I mean, the major fragments on the dorsal aspect, the ulnar cortex is fairly intact here. That's what I can see. There is some, as I said, intra-articular floating fragments there in the center portion. That is also there. And so you can see that shadow, overlapping shadow there, which basically means that it's compression of the subchondral bone there.
So there is one volar lunate fragment is also there, sir.
Correct. Correct.
Yeah. So this is the coronal and sagittal sections.
Yeah. The sigmoid notch appears fairly intact, but as you mentioned that there is a lunate facet also separated out from the main fragment.
Yeah, if you'll see this side, sir.
Correct.
Yeah. So this is 3D CT scan.
Okay.
If you'll see on the volar side, this is the volar lunate fragment.
Yes.
And this is kind of a rim fracture, if I'm not wrong. It's not because it's very close to the volar rim.
Yeah. I mean, I would not put it as rim as such because there is decent amount of subchondral surface still intact there. I mean, rim is where even the subchondral area that margins are blown up. It's almost the capsular attachments are avulsed.
Like a avulsion of the capsule with a flake of bone.
Yes. So radius scaphocapitate and the capsule, everything is taking away that chunk of bone. But here it doesn't seem so. But yes, it's a blowout kind of injury there. Yes.
So how to deal this fracture, sir? So you want to do the close reduction, cast, pinning, external fixator, or the ORIF? If you want to do the open reduction, what should be the approach? It is dorsal or the volar approach, and what would be the choice of implants?
Yeah. I mean, basically, you need to go with an open mind here and check under C-arm. The same principles, what I've told, interop, check the close reduction, see what's happening there, screen the wrist and see, and take a decision whether you want to go dorsally first. You might sometimes want to go both sides, but otherwise, if I saw the volar cortex completely intact, except on the lunate surface area. But yeah, primarily, I would approach volarly. And if required, I would put an additional dorsal kind of an incision in this patient.
Can I just add something
Yes.
here?
Yes, sir. Please, Ravi sir.
We had this, Rickley and Regazzoni gave us the column concept, but Peter Brink and Regazzoni, they came up with the key corner concept, and you take the intermediate column CT and then which way the lunate goes, they give us the key corner, and that should determine the approach. Where in this case, we look at it, you would think probably we should go dorsal. But then, we all know the problem of going dorsal. We can get a very good fixation, but obviously dorsal implants have not been very popular. Number one, because of implant problems. Even the low profile implants will have some sort of, tendon irritation problems. You're always not as comfortable as you're putting a volar plate, thinking of tendon problems. So if you can bypass that way, so if you see that the segments, I saw on the CT, they look fairly long. So one technique which I think is now, very underused, and I think Anil very quite nicely mentioned that he uses it a lot, and I do that often as well. I use a lot of intrafocal wires, to achieve a preliminary reduction. So you reduce it, you put a dorsal couple of intrafocal Kappanji wires, and then you go volar and you fix it, and then you reassess your fixation. But as Anil said, you won't hesitate if you feel that the volar screws aren't holding the dorsal cortex, or you don't have a big enough piece. You can, if you are happy with the volar wires in the dorsal intrafocal wires, you can keep a cast with a volar plate for 3 weeks. The radius is not like the elbow, and it's a forgiving joint. and that will save you the trouble of putting a dorsal plate. But then if you want to, you can easily open up dorsally and put a small plate. You can do dual incisions, no problem at all.
And also the dorsal fragments are not, see, if you see that they're thin fragments there. It's not a big chunk there, so you can still go Ulnar and hold on to them. And happy that the sigmoid notch is intact here, and there is that lunate facet which you would like to primarily assess from the Ulnar side.
Correct.
Anup sir, you want to ask something? Unmute yourself, sir. Please unmute yourself.
Yeah, probably if we look at these CT and if we find that the volar fragment is definitely intact and it's a big chunk, the whole thickness is on that side. And if you look at the dorsal, it's a thin fragment. So probably it's my thought that if we try to fix it from the volar aspect, it may not hold well those screws. Because no, as a concept, we try to have at least a millimeter less than the whole thickness of this so that we do not cross the cortex. So maybe operatively, it may be difficult to hold this dorsal fragment, particularly by the volar plating. If we can get away really with the volar plate and get a good hold, then it's fine. But looking at these CT, I am little apprehensive that this will hold well with the volar plate or not.
My decision making is basically depending on the amount of dorsal fragment there. So if it's crossing beyond 50%, I would like to go dorsally first. If it is less than that, I would still go Ulnar because I would still be able to catch those fragments. And they're all very thin, powdery kind of fragments there, and they'll always heal well. And as Ravi was telling, that we have more problems on the dorsal side for whatever reasons. It could be implant, it could be the tendon, it could be the approach, it could be the skin directly onto that without much coverage for the implant. So in that sense, you err more on towards the Ulnar side. If you take that 50-50 line there and then you see which is the major fragment. As you correctly said that the dorsal volar part is intact, the lunate is slightly going off with the dorsal fragment. Ideally, if you go by the book, you should go dorsally first. But then in this case, you see they're all very thin fragments there, and you can still hold on to them and it will heal. It won't cause any major problems. But as Ajit was pointing out repeatedly, the lunate facet needs to also be addressed. And if you just go dorsally, you might not be able to do it.
Dr. Anil.
Yeah.
Is there a possibility of going back first and put a buttress plate there and then go ventral and fix it with ventral plate, and then you can remove if you have a good buttress?
Absolutely. That's what Ravi was telling.
Then you can remove that dorsal plate, because at least then you didn't. Otherwise, you may end up in fixing with a broad distal radius, maybe.
Yeah, but Ravi gave an easy solution where you could just hold them on with just a Kapanji's kind of intrafocal kind of wires, and that still serves the purpose. You don't have to really open and put a plate. You can still be percutaneous and do the job.
That's fine.
That's a smarter way of doing it.
Sure.
Okay, so as I'm not much experienced, so I had a lot of fear of that volar lunate fragment that should not come out, that the wrist should not be subluxated on the volar side. So this is a intra pictures where this is the fracture site, and you will see that on the radial side it was extended on the radial styloid fragment was separate. This is that cortex volar rim part of the distal radius. So I put this rim plate. I've reduced. I put the clamp from the to hold the dorsal fragment with the clamp. And I assess the joint with the wires to find out the joint, and then I put this volar rim plate, and then I fixed it. So if you'll see this is 23-degree lateral view, this is the PA view, and this is the lateral view. So this is what I could have achieved intraoperatively.
Very, very nicely done, Ajay. And one other thing, if you have concerns of the dorsal fragment, one other technique would be for you to go through from the Ulnar side and just pass sutures and get them back, with the soft tissues. So that's another technique which a lot of people don't use much, even though it's a very good technique. There are nice videos available of that. So to the same locking holes, you can just put a hypodermic needle and put in a fiber wire or ethibond, and then catch those fragments, and just, you don't really need a reduction. You just want to just tap them back and get them back and tie it to the plate itself. That's one way of doing it.
That's through the fracture side from the volar side.
Through the fracture side on the volar side, yes.
So this is a post-surgery 2 week, after 2 weeks, this X-ray. And so the important thing, what we should keep in follow-up of this patient when you are putting the rim plate, there's always a possibility of the FPL irritation, and always keep patient in the follow-up. So because it may possible that if you lose the follow-up of the patients and patient present with the rupture of the FPL, especially if you're putting the rim plate or the plate which is very quite distal, and early implant removal is indicated. So, but I lost the follow-up of the patient. He came me after 1.5 years later on. Just 2-3 days back, he came to me. Luckily, his FPL is intact. He has no pain, no irritations, no kind of tenderness or the FPL tendon. And this is the X-ray of 1.5 year follow-up. And this is the moment he has. I think almost he has a reasonable movement.
Very nice movements.
Excellent.
So almost full flexion, full extension, pronation, supination. So there's another case.
Are you still going to remove the plate?
Sir?
Are you going to remove the plate?
Yes. I've advised him. I want to remove the plate, sir.
You write it in that, otherwise if it comes back, then it's a problem.
So this is another patient. Just 2 days back, she came to me, and I think this patient has came for the webinar only. This is 16-year-old girl. She is right-hand dominant student. She has presented to me with radial-sided wrist pain since last 1 year. She has difficulty in the lifting the heavy weight or the loading of the wrist. On examination, I found there was mild swelling, or you can say the bony lump or bony swelling on the volar and radial side of the wrist. On the flexion and her movements, basically flexion extension was grossly restricted and painful. Pronation, supination was the normal, and there was no neurovascular deficit, median, ulnar, radial, all the nerves was normal with good pulsation of the radial artery. So this is the movement she has. You will see on this the radial side, on the there's a volar aspect of the radius. There's some kind of lump. Her movements are restricted. Flexion is this much, extension is this much, pronation, supination is fine. So I did the X-ray, and this is the X-ray. Pankaj sir?
So she had no trauma, I guess?
No trauma.
So she has some kind of a tumor of the scaphoid.
Yes, sir.
And I see the proximal pole of the scaphoid is dense.
Yes, sir. So we have the MR also.
Yes, so let's see the MRI.
So this is the MR.
First thing I'll do is I'll take a biopsy.
Open biopsy or FNAC, sir?
I'll open it and take a curate. I'll not do FNAC. I'll curate it.
Dorsal approach, volar approach, sir.
Question is, what are the possibilities?
Yes, sir.
So we are looking at some kind of a tumor, and I don't have a diagnosis in my hand. So that's why I'm going for a biopsy. What's the differential diagnosis? So we are talking
about GCT or ABC, because it is a 16-year-old girl. So most probably it is not the GCT. Most probably it is the cyst, bony cyst.
Yes, cyst. So I'll take a biopsy.
Nowadays, Ajit, can I come in?
Yeah, please, sir, please.
Yeah, I mean especially the subcutaneous kind of bones. FNAC definitely not, as sir said, but definitely you can have an ultrasound guided biopsy or even a CT guided biopsy for superficial bones, even though orthopedic classic teaching is for an open biopsy in musculoskeletal tumors. But when you look at these bones, small bones, especially even GCT distal radius, which are quite big with a swelling and easily accessible, we can go with an ultrasound guided biopsy, take out samples from different areas if you want. FNAC will definitely miss out in it's obviously not histopathology, it's a cytopathology, what you see. But these kind of bones, instead of an open procedure, there's a middle path of ultrasound or a CT guided biopsy.
What do you need a biopsy?
Yes, sir. Yes, definitely, sir.
Okay.
Ajit, you
Is
had
there
a
any
biopsy?
chance of infection?
No, sir. I don't have biopsy of the patient.
Is there any chance of infection in this patient?
This is the blood investigation, sir. So I think her ESR is 17 and CRP is less than 2. Counts are within normal range.
Yeah. What next?
So you have ruled out infection.
Yes, infection is ruled out, sir. So absolutely, there's no evening rise of fever or any kind of fever at the. So MR has done and they have reported it as and they have just suspected it cannot be definite to diagnosis, but it looks like they are reported as a giant cell tumor.
How long is the problem?
Since 1 year, sir. 1 year.
Dr. Anil, you talked about percutaneous ultrasound guided or CT guided biopsy. That you would like to have the core biopsy CT guided? Or,
it's not always core. It's you can take from multiple sites. I mean, ultrasound will give you different signals in different places. So a good sonologist would take the samples from all the areas, and whether it's from the fluid, from the center, from the periphery, all areas can be sampled nicely. Multiple samples can be taken so that you don't miss out on the basic histopathology picture you would like to get. So in a way, it is much better, because in these small bones, you're in a dilemma between, when you go in for just a biopsy, whether you want to curate out, it's a benign tumor because it's a slow growing tumor, 1 year old, no pain, only nauseous come. So we know it could be a giant cell variants. It could be anything, GCT, enchondroma, I mean, any of these things could be there. So it's basically to be taken as a GCT variant. We've had patients with chondroblastoma and so many other things, especially young patients, physis not closed. So that's one possibility we have to see. Intraosseous ganglion, any of these things we have to see. So in that sense, it's still safe for us to go for these kind of biopsies.
Can you go back
suppose, yes,
sorry.
sir. Yes, sir. Please.
Can you go back to the MRI, please? Other one. Next, previous.
One more. Yeah.
One more.
The first section, Ajit, which you showed.
Okay. So,
yes.
This one?
Yes. No, the previous. Yes.
This gives a fluid signal also.
That's what.
So it could be anything. I mean, it could be a ganglion cyst. It could be, a GCT variant. Like Anil said, it could be anything.
So what should be treatments? Considering if it is giant cell tumor, if it is bone cyst, it is ganglion, if it is, if any kind of malignancy, or you can say, I don't suspect any kind of.
As Anil rightly said, it's slow growing. We don't see any breach in the on the cortices of the bone. So probably we are not looking at a malignancy here. So if it is a bone cyst, I think we are curating and bone grafting. But if it is GCT, then I think I'm looking at proximal row carpectomy.
Suppose it came to the GCT.
Because this is involving even the proximal pole. If it was not involving the proximal pole, I would have excised the distal pole, like what is called as the Malerish procedure. But it's the whole length of the scaphoid is involved here.
Yeah, whole length has involved.
So your PRC decision is because of the chance of recurrence, or because of the vascularity you're thinking of, because even the proximal pole is involved?
Because if it is giant cell, I am looking at the recurrence. I am not very comfortable with micro drilling and the burring. I would rather excise it once for all. Again, the word guarantee.
No, even in the first instance, I mean, it's not recurrent giant cell. So.
If it is giant cell tumor, I'll excise it. I'll sleep with peacefully. I'll not do any micro drilling, micro burring. I'll not supplement it with donaximab or anything. I'll recommend to the patient proximal row carpectomy. I think in last 2 years, I've done at least 6 or 7 of them. In fact, surprisingly, 2 patients said it was in the proximal phalanges. Said they came prepared for amputation. That if you don't amputate, we'll have it amputated somewhere. They didn't want to listen to anything. So coming back to this specific, if it is giant cell tumor, whole length involved, I'll do PRC.
Considering her age also, as just she's 16-year-old, sir.
Doesn't matter. Recurrence is the bigger problem.
Anil, your preference, what you would like to do?
I would be a little more conservative because it's a first instance, and as you said, younger patient. Open up, see what it is. So it is, I mean, you know that it's a GCT the moment you open up with the necrotic tissue there inside. So I would do a thorough curettage and see how much of the scaphoid is involved. See, for us here, my concern is more of vascularity. How much you have to curate and what you have to fill in. Now we know if it's a GCT, with bone graft, the recurrence rate is quite high. And that's why we use bone cement even for distal radius very commonly, so that you reduce the chance of. Here with the cement going in, you know, very rarely somebody would put a cement inside a scaphoid, if at all somebody wants to put it. In terms of thinking about recurrence, but at the same time looking at vascular. So it's a dicey thing for scaphoid. So I would still go do a thorough curettage and extended curettage, in the sense that open up a big window. The moment we open, you know, if it's a necrotic tissue, it's GCT. If it's cyst fluid comes out, or if it's enchondroma, there's a chalky material. So on table, you know that. So the moment you see that necrotic tissue, make a bigger window there on the ulnar aspect, curate out nicely. I use some amount of, in distal radius, I use cautery and other things for an extended curettage, and then put a cement there. But here, my concern is vascularity. So I would be a little more conservative, put a good bone graft and come out. Wait for the recurrence and see what happens. And probably tell the patient that next time it will be a PRC.
So patient has to be a part of the decision making, whether you are doing more conservative or radical surgery. Patient has to be part of.
Give a chance for the first time, wait and see. Tell the patient, as sir said, and make sure that patient understands that there might be a second surgery, and that would be a salvage surgery.
So approach should be volar approach.
No, dorsal approach.
Dorsal approach.
I mean, sorry, for the curettage.
For the curettage.
For the volar approach, I would go volar approach.
Okay. So Ravi sir, what's your opinion?
I would agree. I mean, it all has to be informed consent making, and while it all depends. What Anil said has definitely got merit. If you could have a luxury of a two-stage surgery, depends upon the patient. If otherwise it is unlikely, financially, logistically, the patient is agree. If you want to have one sure shot, especially in a small bone like radius, like scaphoid, if I have any doubts when I open up that it is going to be GCT, I won't even try to salvage. I will go for but that would be factored into the counsel. So again, the kind of practice which I have, usually I practice with the gun point to my head, so it's always with a guarantee, or that profile of patients will take you either to court, or they'll be willing to create problems for you. So you do the more standard reliable, unless you can include the patient in the counseling and the decision making, and they seem to be on board, get everything explained and written and documented, and then you could go with a two-stage, ideally two-stage, but you have to play your cards according to what you come up with.
Sounds good. Okay, so if we don't have any question, anybody want to ask any question about any topic?
On this, Ajit, I just want to ask, Anil, would you like to remove that particular part of the scaphoid as a whole? Because it's all ballooned out all around the cortex. If you look at the MRI, it's all ballooned out, absolutely thin cortex of almost 2/3 of the scaphoid. So would you like to absolutely remove that 2/3 part of the scaphoid, leave it 1/3 only? Because ultimately it is going to collapse if we are not putting any graft or any cement or anything inside. If we are just
I would definitely put a graft. I mean, I would not come out just with curettage. Definitely graft will be there. But as sir said, distal pole excision is an option, but not the distal 2/3 of the scaphoid is not an option. then you as well do a scaphoidectomy, and you can do a capitolunate fusion or something
You
like that.
can do, yes.
Yeah.
That's what I was trying. So
Yeah.
rather than looking at the PRC, if we remove all of the scaphoid and do that, that would be
that's a thought for younger patients where you want to do a scaphoidectomy and a 4-corner or a 2-corner fusion is an option instead of doing a PRC. So younger patients, we would go more towards the limited fusions, limited arthrodesis after scaphoid excision. That's definitely an option.
Yeah, because this is a young patient, 17-year-old. So we would be avoiding the recurrence, chances of recurrence or the second surgery also. And again, would be doing something which is limited to certain part only.
Yeah, as Ravi said, if patient is one single surgery, I think that would be the way to go. Remove the scaphoid once you know when you're in and you know it's a GCT. I mean, you can make out intra, definitely it's a GCT.
On table, yes.
Yes. So when it's the classical necrotic tissue, when you see that and you know it's a GCT, I think, and if you don't want a second surgery, recurrence and all those headaches, remove scaphoid. I would do a capitolunate fusion. Yeah, that would be one.
Okay, sir. Thank you, sir. So, with Sanjay Dhawan sir's president's permission, sir, if there's no question, then probably I will invite, I'll request our Honorable President of Kanpur Orthopedic Association, Dr. Nadeem Farki, sir. So please give vote of thanks to our faculties and panelists.
Thank you, Ajit. At the outset, I would like to thank Dr. Sanjay Dhawan, our president, and Dr. Anup Agarwal, secretary of the UP Orthopedic Association, for initiating such a wonderful series of Friday lectures, which I think will be very beneficial to all the orthopedic surgeons practicing in UP. And I would like to thank our esteemed faculty for taking time off their busy schedules to giving us such excellent lectures. And there was very good discussion as well after the lectures. And I think it will tremendously benefit all the orthopedic surgeons practicing in UP. And I'm very thankful to all the people who have joined and listened to these lectures, and I'm sure they would have benefited very much. And this week, the case presentations were by Dr. Ajit, but in subsequent lectures, I would hope that other orthopedic surgeons would put up their cases and present their cases in these lectures. And finally, and not the least, I would like to thank our very dynamic and dashing Dr. Ajit Tiwari for organizing this lecture. Thank you very much.
Thank you, sir.
Thank you so much, sir. Thank you, Anil, for coming in. Thank you. Bye-bye. Bye-bye, everybody.
Good night, sir. Good night. Take care, sir.
Thank you so much.
Thank you. Thank you, sir.
And very important person, Dr. Neeraj Bijlani. He had done job. No?
Yes, I forgot to mention.
Neeraj, we thank every week now.
Thank you. Thank you.
Thank you, sir. Thank you so much.